Thank you for the kind introduction and also the warm welcome from all Vietnam colleagues. Good afternoon for all colleagues in this room. Today, my topic is about the evolution of the endurance limb modified for internal iliac preservation during EVA procedure. This is my workplace in the northern part of Thailand in the Chiang Mai University. At the northern part, we have two large hospitals that we share the cases and also do the complex case together. Okay, let me introduce about the internal iliac preservation. As we know, there are many choices for preserve the internal iliac artery during EVA procedure. Some of the surgeons prefer to do the embolization for the internal iliac. Some do the hybrid procedure like open bypass or use the bell bottom or parallel graft. For now, we have the iliac branch device as the commercial device, but there are some limitations for the IFU and also in some center that still didn't have this device available. And for the IFU, for the iliac branch device, they require the common iliac bifurcation more than 16 to 18 millimeter, and also require the landing zone in the external and internal iliac artery around 10 to 20 millimeters. But for the Asian population, we also know that we are much has the patient that out of IFU for the standard device, and also there are more cases in Asian population that has narrow iliac anatomy. This is the report from other colleagues that show that around half of Asian population does not fit to the IBD device. That's why the PMAC is one of the choice for treating such a case like this. In the case that the common iliac diameter less than 16 or 18 diameter, that will cause the unopen of the standard device, and also in some center that has the device unavailable, PMAC is maybe the choice. But for the length, it's not much problem because we have many adjunct technique to overcome the length problem. And some suggest to deploy the EVA first and followed by do the standard IBD on the contralateral side. And this is the previous design for the PMAC to do during EVA procedure to preserve the internal iliac device. Some use the limb of the EVA and some use the other AFX limb to do the PMAC IBD. And some use the cook, and you can see that the last picture, we adopt this technique to use the endurance limb for modify. After we do some case with the single fenestration, we develop more and more for PMAC technique to preserve the internal iliac artery during the EVA procedure instead of the use of standard IBD device. I will show you our case. The first case is 88-year-old male with history of sigmoid colon and underwent the operating. And now he presented with 6.4 centimeter infrarenal aortic aneurysm. For the CT scan, you can see that it was the infrarenal aortic aneurysm, and for the left common iliac artery is quite short and narrow, and still have a patent both of internal iliac artery. Actually, we can do the embolization for the left internal iliac and land on the common iliac bifurcation, but for this case still has a sexually active and he concerned a lot about the sexual function, so we decide to preserve both of internal iliac artery for him. And this is the planning for the case. We use the standard EVA device and use the 16 by 10 endurance limb on the left side for doing the single fenestration PMAC. The step, we deploy the endurance limb on table, completely deploy, and use the overlap marker here to do the single fenestration just below the overlap marker, and reinforce around with the double loop snare wire suture with the 5O proline. This is the final picture of the modified endurance limb that do the single fenestration. And after that, we insert a preloaded wire by puncture through the delivery system and use 018 guide wire insert. You can see that the guide wire will go out and into the fenestration different from the T-wire that Dr. Sun already presented. After that, we resheath the endurance limb, and this is the final picture for the modified endurance limb. The operating steps start with the femoral catheter crossover to receive the preloaded wire. And then we insert our device up according to the internal iliac artery opening here, and the fenestration placed a bit higher to the orifice. And then we partially deploy the device until the fenestration open. You can see that in this case, even the common iliac is quite short, we also can do this kind of technique and insert the long sheets, follow the preloaded wire that we already done. After we select into the internal iliac artery, we insert the bridging stent and do the kissing balloon for internal and external iliac artery to make sure that the bridging stent not compress the external iliac artery lumen. And then we proceed to do the standard EVAR step. For the bridging limb, you can see that I always use longer limb and put against the aortic wall to make it seal nicely and curve to the bridging part. And the final angiogram is look quite good, and we can preserve the internal iliac artery. After we perform many cases for the single fenestration, we try to adapt more to do the outer branch design like this. But you can see that the outer branch design may require the larger sheet to capture this part in because it's quite bulky. So we didn't do this design anymore. The next case will be 87-year-old male with severe pulmonary disease. He came with symptomatic infrarenal aortic aneurysm, and you can see that on the left side is not quite healthy of common iliac artery, and we plan to preserve the left internal iliac artery because we need to get more sealing rather than the outer branch. So we decide to do the inner branch, mini inner branch design by do the oblique cut of 6 mm PTFE, suture the inlet and outlet like the previous case. And you can see that the oblique cut design will not compress the IIA lumen. We also use the 018 guide wire for the preloaded wire. And the step for the operation is quite the same. We orientate the device, put the device up, and partially deploy until the branch opening. You can see the marker of the mini inner branch has a 2 ring of the inner branch. And this is the final outcome. Until now, we follow up to 6 months for this case and still has no endoleak. And the last case will be 60-year-old male with pulmonary disease and symptomatic AAA. You can see that in this case, the internal iliac is larger than the previous 2 cases, and due to the limitation of the endurance limb, we can insert larger than 6 or 7 mm for the bridging stent. So we cut some part of the endurance strut and fix it into the oblique cut of PTFE 8 mm. And we call this design as a fusion branch, some part inside and some part outside. And the same operative step, we deploy and select into the internal iliac artery and deploy the bridging stent by use the B graph. You can see that the one strut will fix here and make it more stable during deployment. And this case had a bit challenging for select into the internal iliac artery, but finally we can get inside and use balloon tracking to insert a bridging stent into the internal iliac artery. The follow-up CTs look quite good without any endoleak, and we also preserve the internal iliac artery. I record and report our technique in the Journal of Endovascular Therapy last year by show the evolution of the many design that I've already done. And I collect the data and present my outcome at Link 2026, but at that time the outcome is not reached 1 year yet. So today I will do the update outcome for around 1 year follow-up for my PMEC. You can see that compare the PMEC group to the IBD group, the comorbidity is quite more in the IBD group, but it may not significant effect to our outcome because we focus on the endoleak and also the internal iliac branch patency. In the PMEC, IBD group has a little bit lower common iliac diameter, but not significantly different. And for the primary outcome, you can see that in the PMEC group, we lost one patient due to the hemorrhagic stroke, so we got only 9 in this group, but still has a 100 patency of the internal iliac branch and also no endoleak. Compared to the IBD group that has one case that the internal iliac branch already occluded at 1 year follow-up. The operative time is quite the same, but for the PMEC, we need a back table modification around 20 to 1 hour to make the modified endurance limb. But I think if we practice more and more for the single fenestration, we can drop the operative step for this part around only 20 minutes and do it during the anesthetic preparation. So the overall operative time is quite the same. For my conclusion, I think the PMEC is one of the choice that we can do, and we have 3 design for the PMEC, include single fenestration, mini inner branch, and the fusion branch design. The single fenestration is easy to do, but it has a limitation for the internal iliac branch that more than 6 or 7 millimeter. We have to skip to the fusion branch design. But if we want more sealing at the bridging stent, we can use the mini inner branch design instead of the single fenestration. And at this point, I would like to conclude that if we have the standard device and the patient fit with the standard device, it may better to go to the standard device. But if the device unavailable or the patient is out of IFU for the standard device, PMEC is one of the choice to treat in this kind of patient, but still need more long-term following up for the outcome, and I will report my long-term outcome in near soon. Thank you for your attention.